Greetings out there. In this video, we shall discuss about the neurological assessment and also cardiovascular assessment in a patient with ED extubation. So, when assessing a patient for extubation, it is important to ensure that the patient is fully awake and able to participate in the independent breathing. Sedation should be weaned, and time should be given to allow the patient to regain full consciousness. Small doses of analgesia or anxiolytic agents may be necessary to maintain patient comfort while sedation is discontinued. Dexmedetomidine is an excellent anxiolytic that does not affect the respiratory drive and may facilitate extubation in patients with agitation from pain or discomfort due to endotracheal intubation. Dexmedetomidine should not be given in bolus doses, as this is associated with significant bradycardia. Okay, so the onset of therapeutic effects usually starts within 15 to 40 minutes. Dexmedetomidine used to facilitate safe extubation should be used only if the clinician is certain that the increased respiratory rate is from agitation due to endotracheal intubation, endotracheal tube, not from respiratory or cardiovascular derangement. Clinically, the patient should spontaneously achieve normal or high tidal volumes. A blood gas may help discriminate apnea due to agitation versus ventilatory insufficiency. A high respiratory rate of secondary to agitation will be associated with respiratory alkalosis and a low PCO. A normal or elevated PCO2 with high respiratory rate should trigger the clinician to consider that the patient's agitation and tachypnea as a compensatory. High respiratory rate secondary to agitation will be associated with respiratory alkalosis and low PCO2. A normal or elevated PCO2 with a high respiratory rate should trigger the clinician to consider that the patient's agitation and tachypnea as compensatory mechanism. Once the patient is awake, he or she should have a consistent neurological assessment and be able to follow commands. Asking a patient to lift his or her head should always be included in the neurological assessment, as cervical mobility and strength are vital for clearing secretions and maintaining a patent airway. So this is very important in case of ED extubation. Coming to the cardiovascular assessment or hemodynamic stability, ensuring cardiovascular hemodynamic stability before extubation is a critical component of assessing the readiness for extubation. An extubation candidate should be liberated from use of inotropes and vasopressors. One suggested criterion for hemodynamic stability includes the following, that is oxygen saturation more than 92%, heart rate of less than 100 beats per minute, and respiratory rate of less than 30 per minute, and systolic blood pressure of greater than 90 millimeters of mercury unassisted by vasopressors. No active cardiac ischemia or unstable arrhythmia should be noted. And good clinical judgment would likely include these recommendations along with the patient's hemodynamic baseline. Weaning induced cardiovascular dysfunction is a well described uh, phenomenon and a common cause of extubation failure. So we must be careful regarding this. And risk factors include volume overload, depressed LV dysfunction, then diastolic dysfunction, then a structural heart disease, and obesity, and chronic obstructive lung disease. This completes the video. Thank you very much.